Hi everyone, it's Deanna Hunt, and as part of our antibiotics series, today we're going to talk about bacteriostatic inhibitors of protein synthesis. Now, however, unlike the aminoglycosides, which are bactericidal, the drugs considered here are largely bacteriostatic. And really what this means is that they suppress bacterial growth and replication, but do not produce outright kill. In general, the drugs presented here are considered second-line agents, and they're used primarily for infections that are resistant to first-line agents. The first group we're going to talk about are tetracyclines. There are 4 members of the tetracycline family that are available for systemic therapy. They include tetracycline, demyclicycline, doxycycline, and minocycline. Tetracycline is used in various infectious diseases, including mycoplasma pneumonia, Lyme disease, anthrax, H. pylori, cholera, chlamydia, rickettsial diseases, treatment of acne, PUD, periodontal disease, oral therapy, and topical therapies. Now, extensive use of tetracycline has resulted in increasing bacterial resistance. And because of resistance and because of antibiotics with greater selectivity and less toxicity, the use of tetracyclines has actually declined. Today, tetracyclines are rarely used as first-line drugs, but the ones that are used as first-line drugs are listed again on this slide. Individual tetracyclines differ significantly in their pharmacokinetic properties. Of particular significance are the differences in half-life and route of elimination. Also important is the degree to which food decreases absorption. This slide does a nice job describing the pharmacokinetics of tetracyclines, so I would take a moment just to look at this. This slide reveals different tetracyclines used, including the trade names, route, and dosing. As you can see, there are a couple tetracyclines that are IV administered. Tetracyclines should not be administered together with calcium supplements, milk products, magnesium-containing laxatives, and most antacids because they contain magnesium, aluminum, or both. Now, tetracyclines can form non-absorbable chelates with certain metal ions, including calcium, iron, magnesium, aluminum, and zinc. Substances that contain these ions include milk products, calcium supplements, iron supplements, magnesium-containing laxatives, and most antacids. If a tetracycline is administered with these agents, its absorption will be decreased. To minimize interference with absorption, tetracyclines should be administered at least 1 hour before or 2 hours after ingestion of chelating agents. All tetracyclines can increase the sensitivity of the skin to ultraviolet light. The most common result is exaggerated sunburn. Advise patients to avoid prolonged sun exposure, to wear protective clothing, and to apply sunscreen to exposed skin. There are some adverse effects to be aware of with tetracyclines. The first one we're going to talk about is GI irritation. Tetracyclines irritate the gastrointestinal tract. As a result, oral therapy is frequently associated with epigastric burning, cramps, nausea, vomiting, and diarrhea. These reactions can be reduced by giving tetracyclines with meals, although note that food may decrease absorption. The second effect is effects on bones and teeth. Tetracyclines bind to calcium in developing teeth, resulting in yellow or brown discoloration. Hypoplasia of the enamel may also occur. The intensity of tooth discoloration is related to the total cumulative dose. Staining is darker with prolonged and repeated treatment. When taken by a pregnant woman after the 4th month of gestation, tetracyclines can cause staining of the teeth of the infant. Tetracyclines taken by a pregnant woman can also suppress the growth of the long bones in the premature infant. This effect is reversible, though, after discontinuation of the treatment. Another effect is superinfections. As a reminder, a superinfection is an overgrowth with drug-resistant microbes, which occurs secondary to suppression of the drug-sensitive organism. There's also liver toxicity and renal toxicity. Tetracyclines can cause fatty infiltration of the liver. Pregnant and postpartum women with kidney disease are especially at high risk. Lastly, there's the renal toxicity. Tetracyclines may exacerbate renal impairment in patients with pre-existing kidney disease. This slide talks about tetracycline and the uses across the ages. As you can see, tetracyclines should not be used in pregnant women or in children younger than 8 years old. Additionally, they can cause drug interactions that you should be aware of. Key prescribing considerations for tetracycline are listed on this slide, and a lot of them are a repeat from what we had previously talked about, but do take a moment to review this. Now we're going to discuss another bacteriostatic inhibitor, macrolides. Macrolides are broad-spectrum antibiotics that inhibit bacterial protein synthesis. They're called macrolides because they're big. Erythromycin is the oldest member of the family. The newer macrolides, azithromycin and clarithromycin, are derivatives of erythromycin. These drugs are active against most gram-positive and some gram-negative bacteria. You can use them if the patient's allergic to penicillin. Here's a table of commonly prescribed macrolides, the trade names, the routes, and the dosing. As you can see, azithromycin and erythromycin is both given PO and IV, and you can see the total adult dosing for both adults and pediatrics. We are going to use erythromycin as our prototype as we discuss macrolides. Erythromycin has a relatively broad antimicrobial spectrum, and it's preferred or alternative treatment for a number of infections. This drug is one of our safer antibiotics. Antibacterial effects result from the inhibition of protein synthesis. Erythromycin binds to 5-OS ribosomal subunit and thereby blocks the addition of new amino acids to the growing peptide chain. This drug is usually bacteriostatic but can be bactericidal against highly susceptible organisms or when present in high concentration. Erythromycin has an antibacterial spectrum similar to that of penicillin. The drug is active against most gram-positive bacteria as well as some gram-negative bacteria. Bacterial sensitivity is determined in large part by the ability of the erythromycin to gain access to the cell interior. Erythromycin is the commonly used antibiotic, and the drug is a treatment of first choice for some different drugs listed within my notes, including those with penicillin allergies. Several infections respond equally well to macrolides and tetracyclines, and both are drugs of first choice for certain chlamydial infections and for pneumonia caused by Mycobacterium pneumonia. Listed on this slide is key prescribing information for macrolides. As you can see, you do want to identify high-risk patients because you want to use this in caution with patients with QT prolongation. This is one of the side effects that you absolutely need to be aware of. Now we're going to move on to other bacteriostatic inhibitors of protein synthesis. The other drugs specifically that we're going to talk about are clindamycin and linezolid. Clindamycin is active against most anaerobic bacteria, including gram-positive and gram-negative, and most gram-positive aerobes. Gram-negative aerobes are generally resistant. Clindamycin is usually bacteriostatic. However, it can be bactericidal if the target organism is especially sensitive. It's used widely as an alternative to penicillin. Clindamycin is the drug of choice for severe group A streptococcal infections and for gas gangrene. Clindamycin does have a black box warning. Clindamycin can cause potentially fatal C. diff diarrhea. Patients should promptly report any diarrhea to their healthcare provider. Now we're going to talk about linezolid, which is the first member of a newer class of antibiotics. It's very important because it's active against multi-drug resistant gram-positive pathogens, including VRE and MRSA. Linezolid is a bacteriostatic inhibitor of protein synthesis and has 5 approved indications listed on this slide. It's generally very well tolerated, and the most common side effects include diarrhea, nausea, and headache. Linezolid is an oral suspension, and it does have a drug reaction with certain MAOIs. Now we're going to talk about tetazolid, which is the second oxazolidine antibiotic approved after linezolid. Like linezolid, tetazolid is effective in the treatment of MRSA, as well as other bacterial and skin soft tissue infections caused by sensitive Staphylococcus and Streptococcus species. Tetazolid is used in the treatment of skin and soft tissue infections caused by MRSA, MSSA, and the other antibiotics listed on this slide. The most common side effects associated with tetazolid are again diarrhea, nausea, vomiting, dizziness, and headaches. More serious adverse effects such as neuropathy and myelodepression were also seen. Tetazolid interacts with a few drugs, including MOAIs. Alright, so we've reached the end. As always, with any questions, please email me at dhunt@mccn.edu with any questions.